Hi, I'm Carol Arp. I'm a nurse transplant coordinator at the University of Washington Medical Center, and I'm here today to talk to you about kidney pancreas transplant education. You should have gotten a couple of things in the mail, and one of the things that you would have received is your transplant education manual, and hopefully you've reviewed that before you came here today. Also want to make sure that you keep this. This is a really good resource tool for you throughout the transplant process. So as we talk today, we'll cover a lot of different things. You're all from very different backgrounds as far as where you are in your transplant workup, whether or not you're on dialysis or whether or not you're pre-dialysis. So we'll just try to hit a couple of different things. As far as transplant, the whole reason we're here today is to see if we can make your life better. Sometimes transplant can make your life better, and sometimes transplant can make your life worse. Throughout this whole process, the transplant team will work together with you and your nephrologist to see where you are in the medical process as far as being worked up for transplant, and we'll also determine whether or not we think that the risk is too great for you to continue on with transplant. Transplant's a choice. It's not a cure for your kidney disease. It's an exchange. You're exchanging one set of problems for another. You're exchanging dialysis for transplant. Some patients may determine that dialysis is the best way to go, and other people will decide that they want to pursue transplant. There are many, many different reasons that you have ended up with kidney disease. And interestingly enough, when we look at this slide, you'll see that the highest number of people that are on the transplant list at the University of Washington are those of you who are here for retransplant, which means that we have made lives better. So now you're coming back again for a second transplant. And yes, you can get a second transplant as long as there's no medical issues that would preclude you from being transplanted again. The other main disease process that brings people to kidney transplant is diabetes. Diabetes is the highest cause of kidney disease in the United States at this time. And we'll also talk about that a little bit when we talk about living donors. We want to make sure that if you have a family history of diabetes, that we look at your living donors really, really carefully. And then the other reasons are just an assortment. Another common one is polycystic kidney disease, which is also very common in the population. When we look at whether or not you meet the criteria for transplant and what is the best option for you, you can look at this slide and it'll show you projected years of life for someone when you compare dialysis to transplant. And this is for a non-diabetic patient. And these are different age groups, 20 to 39, etc. Transplant is the lighter color. So you see that for a non-diabetic patient, transplant does extend your life significantly. The next slide is actually pretty, this is pretty interesting. When you look at a diabetic dialysis patient, you can see that there's a very, very big difference in the projected years of life with transplant compared to dialysis. So that's why we really encourage people to come to transplant early on, especially our younger patients. Diabetes, unfortunately, causes a lot of problems, specifically coronary artery disease, which does shorten your life considerably. So there's the good and the bad with transplant. The advantages of transplant, as I was talking about, increasing your life expectancy. We hope that we can make your life better. We want to give you a more normal lifestyle. For those of you who are on dialysis, you know what it's like to have that restriction of going to dialysis 3 days a week, 5 days a week, that 3-4 hour block of time out of your day. You don't always feel really good after dialysis. It's a real roller coaster of how you feel. You go to dialysis, you leave, you're tired, the next day you feel good, and then you start all over again. Transplant hopefully gives you a more even feeling. You don't have those ups and downs. Although I do need to tell you that you're not going to wake up like you felt maybe back in your 30s or 20s. You still have all the disease processes that came with you when you came to transplant. Much, much more freedom with transplant. You still have to follow up with your physician. You still need to come to appointments on time. But for the most part, you can return to a much, much more normal way of life. And we encourage people to return to work. When we talk about a more normal lifestyle, what goes along with that is returning to work. So who's eligible for transplant? This is a really stressful time for people. You come in to see me in the clinic and you think, oh my goodness, am I going to be accepted as a transplant candidate? And there are many things that we look at. There are a couple of rules that are made by UNOS. UNOS is United Network for Organ Sharing, and they write all of the rules for transplant so that all the transplant centers in the United States operate under the same guidelines. We have the same rules, so our patients are listed on the transplant list equally. In order to be listed on the transplant list, you either need to have a creatinine clearance less than 20, and that is a measure of your kidney function. Oftentimes you are not on dialysis at that point in time. You generally don't start dialysis until your clearance is probably down to about 10. And the other way to be listed on the transplant list is with dialysis. So in order to gain time on the waiting list, you need to meet those two criteria per UNOS. Otherwise, the transplant program has certain things that we look at to make certain that you're a candidate for transplant, besides just the medical issues. Number one, we know for a fact that you will not do well without support. You need family, friends, loved ones, someone to get you through this, get you through the workup process as well as the waiting on the waiting list. There's a huge amount of emotional support that's needed. And then after transplant, you'll need somebody to help you get back and forth to clinic, help you take care of your meals, your transportation, make sure you take your medications on time. So it's very, very important that you have support throughout this process. At the University of Washington, we do not have an age cutoff. We look at everyone individually, but we do look at life expectancy. Age, medical issues, and life expectancy all go hand in hand. We may have someone who's 50 years old that's not a transplant candidate. They do not have a good life expectancy even with transplant. And we may have a 70-year-old that would do very, very well after transplant. So we will look at you individually with that. Financial is a huge risk with transplant. You need to, unfortunately, have insurance to cover this. So we look at your long-term insurance outlook. Are you going to be able to have insurance long-term to pay for all these medications? There's risk with transplant. There's risk with everything, unfortunately. Risk with dialysis, risk with transplant. We'll talk a little bit more about the risk a little bit later on, but you look at what is your risk. Does the risk outweigh the benefit for you personally as a transplant candidate? The other thing that we do evaluate all of our type 1 diabetics for pancreas transplant. Only type 1 diabetes can be treated with a pancreas transplant. There are two different types of diabetes, type 1 and type 2. Type 1 means you don't make insulin, and that's where the pancreas is efficient. We do not do islet cells here at the University of Washington. So when you do come in, even if your physician has not referred you for a pancreas transplant, if you are a type 1 diabetic, we will talk about that option with you. So as I said, pancreas transplant is only for type 1 diabetics. For those of you who are diabetics and you have hypoglycemic unawares, in other words, you can't tell when your blood sugar drops, pancreas transplant becomes a life-saving transplant. With a pancreas transplant, we would hope then to normalize those blood sugars, which gives you a much, much more normal way of life. For those of you who are diabetics, you know what that's like, checking your blood sugars frequently. Pancreas transplant will take care of that. We hope that with a pancreas transplant, if it goes along with a kidney as well, that we will at least diminish the progression of those side effects of diabetes. They won't go away. The neuropathies and the retinopathies, all of those bad side effects of diabetes will not go away, but we hope to slow the progression so that they don't get any worse. Now, I told you there was the good and the bad. The bad part about transplant, not a lot. Transplant's actually a really good treatment for your end-stage kidney disease. I have been in transplant for many, many years, and I've given this class for a long time, and I always used to have rejection as the #1 side effect or disadvantage of transplant. And a few years ago, we changed that to financial. I think that financial is probably your biggest hurdle and the biggest disadvantage of transplant. Insurance companies are paying less and less all the time. And the medications are getting more expensive, and we don't have a whole lot of control over that, unfortunately. So the financial burden is huge. The one thing when we talk about disadvantages that I just want to make a point of is After you're transplanted, if you have financial issues, if you have concerns with your insurance company, you're unable to pay for your medications, you need to make certain that you call your transplant coordinator. You talk to your nephrologist. Do not stop taking your medications. We do have little Band-Aids that we can utilize to help you get those medications for a short amount of time. We can't give you medications long term, but we can help you get through whatever has happened with your insurance if there's an issue. So just make sure that you stay in touch with us about that. Then number 2, the second disadvantage of transplant, I think, is rejection. You will all have rejection at some point in time after transplant. The better you are at knowing your body when you feel good, the better you are with compliance, following through with physician's advice, taking your medications on time, and going to get your labs drawn on time, the more apt we are to find rejection early and be able to treat it early. In your manual, it talks about different signs and symptoms of rejection. We're not going to go into those now, but after transplant, your transplant coordinator will really talk with you a lot about what to watch for and what are the key things that we're concerned about. Infection is also a big side effect of transplant. You will be immunosuppressed, which means that you will take medications for the rest of the life of that organ. Those medications depress your immune system, which means that you can't fight off day-to-day infections as easily as maybe other people in your family. You'll get colds, you'll get the flu. It'll take you a little bit longer to get over them, but you just need to use just common sense as far as being around people who have active infections. The things that you don't have a lot of control over are infections such as CMV, which is the cytomegalovirus, and BK, which is also another virus that we're seeing more commonly in transplant. But going back to compliance, compliance is really the key with long-term success with transplant. The better you are at knowing how you feel when you feel good, the more apt we are to being able to address these infections early on. You also have an increased risk of cancer compared to the rest of the population. We all have an increased risk of cancer with skin cancers anymore in the United States. But for patients, specifically transplant patients, there's one type of cancer, it's called PTLD, or post-transplant lymphoproliferative disorder. It's a type of lymphoma, and you have about a 3 to 4% incidence of acquiring that after transplant. Another thing that people think is really, why would this be a disadvantage of transplant? But it's an adjustment to a new lifestyle. Transplant is a new lifestyle. You don't have that dialysis restriction. And also, think about you get a kidney from someone and you feel like, gosh, I need to take really, really good care of this. So people they feel kind of guilty. You know, I've been given this gift and what if it doesn't turn out right? What if I have rejection? So there's, it's quite an emotional adjustment. The other thing, if you can imagine, a lot of people, your only social life is dialysis. You've had to stop work, you're maybe on disability, so the only reason you get up in the morning 3 days a week is to go to dialysis. You don't have that anymore, and so surprisingly enough, that does impact a lot of people. So you've all been referred to transplant. That's why you're here today. The referral process starts when your nephrologist or your kidney doctor either calls me, sends me a letter, or a fax asking that we evaluate you here for transplant. I may get a whole packet of records, I may get absolutely nothing. We review those records, you get scheduled in for this class, and then we do the clinic evaluation. The clinic evaluation is about a 4 or a 5 hour appointment that you come in and you meet with the entire transplant team. You'll have time with me where we can talk about your needs personally. You'll meet with a social worker. The social worker will address financial issues, support issues, how you deal with stress. You'll meet with a dietitian. We want to make certain that you don't have any nutritional issues, and if you do, we need to be able to address those prior to transplant. You'll meet with a transplant nephrologist. A transplant nephrologist is like your kidney doctor, but has gone on to specialize in transplant and kidney disease. That doctor will do a full medical evaluation. talk to you about your risk with transplant and your benefit, and also discuss a little bit about the testing that'll be needed in order to get you cleared for transplant. You'll also meet with a transplant surgeon. The transplant surgeon will talk to you about the surgical risks and the surgery process. After that appointment, the transplant team meets. We meet once a week in what we call selection conference. We discuss what's remaining in your workup, and then I send a letter to you, your referring nephrologist, as well as your dialysis center. It's up to you then to get back in touch with me if you would like to have your workup scheduled here at the University of Washington, which we're more than happy to do, or you can also have it scheduled locally. The one thing that I need you to take control over is you need to call me once you've gotten all the tests that are completed on that letter. Use it as a checklist and mark them off every time you get a test done, and then make sure that you call me and let me know that it's completed. Unfortunately, frequently, I am the very last person that gets the results of your testing. So you just really need to make certain that you stay in close contact with me. And you have my contact numbers, and you've got my business card, it's in the manual. There's no excuse not to call me. So as far as a transplant workup, a lot of it is dependent upon your medical issues, what is bringing you to transplant, what's the cause of your kidney disease. It also depends a lot upon your age. When you come into the clinic, that 4-hour appointment, we will draw a lot of labs. We'll draw basic labs. We'll draw what we call HLA. HLA is human lymphocyte antigens. Those are the markers that we use when we list you on the transplant list. We'll verify your blood type, and we'll draw serologies. Serologies are HIV, hepatitis A, B, and C, and then other viral studies. Additional workup depends totally on your medical history and your age. Many people require cardiac stress tests. All diabetics will get cardiac stress tests. Anybody over the age of 50 will probably also get a cardiac stress test. Vascular exams are common in people who have a history of smoking and cardiac disease. For women, you'll all need a pap smear and a mammogram. Colonoscopy is required on everybody over the age of 50, so if you're watching this right now and you've not had your colonoscopy and you're over the age of 50, you probably need to go to the phone and schedule it so you're prepared when you come in to see me. Urological exams are common in people who have bladder issues, voiding issues. Pulmonary testing, that's usually done on people with a smoking history. Little sideline there. We do not transplant people who are actively smoking cigarettes. We will evaluate you if you're smoking, but we'll also give you resources on how to go through a non-smoking program. So once we get your medical workup and you are medically cleared, in other words, the nephrologist that saw you here and the surgeon clears you for transplant, then we will request financial clearance. All insurance companies require that we send them a letter stating that you've been medically cleared by the transplant program, and we'd now like to list you on the transplant list. The insurance company will then send us a letter stating that yes, you are cleared for transplant. Then I can list you on the transplant list. I generally list people on hold on the transplant list so that you can start gaining time on the waiting list while we complete some of the little tests that may not have been done. You can start gaining time, and then we can also start working up your living donors at that time. Keep in mind that your living donors should call the program now and get started, but we can't do any of their testing that's billed against your insurance until your insurance has cleared you. Hopefully that makes sense. Insurance companies give us a lot of rules, and all we can do is abide by them. So as I said, once you're medically cleared, I'll list you on the transplant list. You are able to do something that's called multiple listing, which means that you can be listed at other transplant programs in the United States. The United States is broken up into regions, and UNOS has broken up the United States into regions. We are Region 6, which is Washington, Alaska, Montana, and Idaho. There are 4 transplant programs here in this region. To be dual listed or multiple listed, you would need to go outside of this region. Many of my patients whose insurance will cover them in another state would go to Oregon, since that's the closest. I have other patients that maybe they reside in Arizona and they also may be multiple listed here. It's easy to get back and forth on the West Coast by plane without a lot of notice. So that can happen. Generally, we would not multiple list anyone who's on the East Coast and would also want to be listed here. We just can't get you back and forth in time for transplant. But if that's something you're interested in, I can certainly help you out with that and we can talk about that. And as I said, please have your living donors call now to get started. So once you're listed on the transplant list, I call you, let you know that you're listed. I send you a letter documenting the date that you're listed. That letter also talks a little bit about your responsibilities on the transplant list. When you get listed, you'll receive this little mailing tube from the Puget Sound Blood Center. It comes out about every 6 weeks. There's inside this little mailer, it's like a little toilet paper tube. Inside of here is a blood tube. You need to take this tube into your dialysis center, have the dialysis nurse draw your blood, label and date the inside tube, repackage it like this, and then you take it to the post office and mail it right away. This keeps your blood stored, a fresh specimen stored at our Puget Sound Blood Center so they can test your blood against potential deceased donors. Also, while you're listed, you need to make sure that you call me and let me know if you've had a medical event. A medical event would be something like a heart problem. Maybe you're admitted for an extended length of time in the hospital for an infection, or some other medical event. I don't need to know about colds or flu, but I do need to know if at this particular point in time you are not transplantable. And the reason for that is when deceased donor organs come available, we only have 1 hour to find people that come up as a candidate for transplant. And if I'm trying to contact you and you're ill, it just takes time away from the next person down the list and it just makes the process a little bit more cumbersome. So make sure you contact me about any events. The other thing is that you need to let me know if you change your insurance. The last thing that we want to happen is to admit you to the hospital for transplant, find out that your insurance has changed, we don't have financial clearance, and then your insurance company is stating that they don't want to pay for this transplant. So that's very important. You need to keep in mind that if you change your insurance, if your employer changes your insurance, many insurance programs have a 1-year or 6-month wait for transplant benefits, which means that if you get called in during that waiting period, they don't want to pay for it. We can always put you on hold on the transplant list. You continue to gain time, but you need to make sure that I know about that. You need to call us to let us know if your contact numbers change. Has your phone number changed, your address? Have you changed physicians? If I'm trying to call you in the middle of the night for transplant and your phone's disconnected, that's not a lot of fun, besides the fact you miss an obvious opportunity to be transplanted. So just make sure you stay in touch with the transplant program about those issues. So when we talk about the deceased donor waiting list, we like to encourage everyone to exhaust your search for living donors, but some people don't have living donors and the only option is to go on the deceased donor waiting list. Unfortunately, the wait for deceased donor transplants is very long. As of 2008, there's about 90,000 people waiting on the deceased donor waiting list for transplant organs. So depending upon your blood type depends upon your wait for transplant. In this region, region 6, blood type A for a kidney alone is about 2 years. Blood type AB is about the same, maybe a little bit more than 2 years. Blood type B is 4+ years, and blood type O is about 3 to 4 years. So that's a very long wait. During that time, many things could change in your life. You could have a medical event that could preclude you from transplant, which is also really important why we need to stay in touch with you. It would be really not in your benefit to be called in the middle of the night. We may find that something's happened that we don't know about and we would have to send you home and not proceed on with transplant at that time. So if we have a little bit of a head start and know that you've had some medical issues, we can take care of those ahead of time. For people who are waiting for kidney pancreas transplant, the wait for that is much less. For example, blood type A for a combined kidney pancreas, the wait is about 6 months to a year. Blood group O is about a year. So the wait is much shorter, many less people on that list. When we look at deceased donors and compare that outcome to a living donor, a deceased donor is someone who has become brain dead, either from some sort of a medical trauma, an accident, or an event, a medical event. Whatever medical event has caused that person to become brain dead can also do a little bit of damage to those kidneys. And sometimes it's really, really hard to tell how much damage that kidney has incurred until the physicians actually see that organ and go to transplant it. With a deceased donor organ, there's increased ischemia. Ischemia is the amount of time that a kidney is outside of the body, not being perfused with blood. So when the donor team goes out to retrieve deceased donor organs, those organs are either being pumped with a fluid or kept on ice and then transplanted into that prospective recipient. Generally, we like to put in all of our kidneys in under 24 hours, but if you think about it, that little kidney's going through some shock by sitting in an ice bath. So sometimes those kidneys don't work right away, where with a living donor transplant, they frequently work right away. Patients are often easily discouraged on the deceased donor waiting list. You can go many years without a phone call. I generally review all of my patients on a yearly basis. You can certainly call me during the time you're on the waiting list, but there's no way that I can tell you where you are on the waiting list. Organs are allocated by degree of match and time waiting. You may have somebody sitting on dialysis right next to you who has the same blood type as you, and they get transplanted before you do. It's because they had a better match with that prospective deceased donor. When a deceased donor organ becomes available and the family determines that they want to donate those organs to anybody in the general population, that information goes to UNOS. Essentially to a computer. You're on the deceased donor waiting list, you're all listed on a national computer. So those organs are matched, as I said, by degree of match and blood type. So the best possible match gets that kidney. Generally, organs that are donated within our region, that 4-state region, stay within this region unless there's a perfect match somewhere else in the United States. You just need to trust that these organs are allocated in a very fair way. We don't pick and choose who gets the organs. So if you have questions throughout the process while you're listed, feel free to give me a call, but people do get easily discouraged. When you're called in for a deceased donor organ, you will be called in as either a primary or a backup. You will be told either to come in and be admitted, stay home, wait for another call. It's a different set of instructions every time. Just because you're a backup doesn't mean that you will be a primary next time. You keep in mind that with each deceased donor, there's a whole new set of antigens, a whole new group of patients that are matched with that prospective donor. So that's why people tend to get a little discouraged. But you need to, as I said before, I'm definitely your advocate. So you need to make sure that you stay in touch with me and let me know if you have any questions. There's another type of donor that we utilize. It's called an expanded donor. When you come in and meet with a transplant team, we'll talk to certain people about whether or not they're interested in an expanded donor. An expanded donor is someone who's over the age of 50, and that particular person has their cause of death was either from hypertension, they probably have a history of diabetes, they may have had a head bleed. We know that those kidneys will not last quite as long as maybe a kidney that was donated because of trauma. So expanded donor kidneys are tended to be offered to our older population, so people probably over the age of 55 or 60. But we'll talk to you about that as far as whether or not you would meet that criteria. So I just said that I was your advocate, and I am your advocate here at the University of Washington. My job is to get you through the process, the referral process, the education process, the workup, and listed on the transplant list. You do have another advocate, and it is through UNOS, United Network of Organ Sharing. And on this slide you can read, the first paragraph is, if you have any concerns or grievances with your transplant program, you are always welcome to call the transplant team at the University of Washington, and there's a phone number. And then the other one is the United Network for Organ Sharing provides a toll-free patient services line to help transplant candidates, recipients, and family members understand organ allocation practices and transplant data. You may also call this number to discuss a problem you may be experiencing with your transplant center or the transplant system in general, and there's a toll-free number. So they are your advocate as well. They want to make certain that everybody in the United States, all of the patients listed on the transplant list are treated fairly and equally. And I think we do that anyway, but we have to have that. So living donor options. We'll talk about living donors now for a little while. And this is one of our living donor pairs. This young man gave to his grandfather. We have many different options. Living related. A living related donor is someone that you're actually a family relation. Mother, father, sister, brother, more distant relations, aunts, uncles, cousins, etc. Living unrelated is a very, very common type of a donor. Spousal donation is very common, or a friend, someone that you're emotionally related to. We don't buy and sell organs in the United States, so there is no financial reward for giving a kidney. Altruistic donors are donors that we do see a fair number of. That's somebody just in the general population, let's say like myself, who would come forward and say, you know, I feel really healthy, my family's healthy, I just want to give my kidney to somebody who needs it. We do work that person up, making certain that there are no psychosocial issues or there's no other, they're not looking for something else to donate this kidney, and that they really and truly are altruistic and just want to give something to someone who's in need. And we treat that altruistic donor when we're looking at recipients, we treat that donor as if they were a deceased donor. So essentially we match that patient against the next person on the transplant list who has the best possible match and blood type compatible. If you were to get a call from your coordinator letting you know that you've come up as a candidate for altruistic donation, we would explain the situation. We would not give you any information about that donor, just like with a deceased donor you get no information. We would actually not even have you meet that prospective donor. The donor doesn't have any information about you either. After transplant, if you both agree and it is your wish, both of your wishes, that you meet or you correspond, we can help facilitate that. But we do not, you know, that's totally up to you. But it's worked out really well so far in our program here. We've done a number of altruistic transplants. The best option for transplant is a living donor. When you think about it, a living donor, you know, it's planned, it's scheduled. You would have better initial function and better long-term results. Oftentimes, those deceased donor kidneys work absolutely perfect. They start functioning right away. But we do know for a fact your living donor is healthy, no medical issues whatsoever. Shorter cold time. Cold time, remember I talked about ischemic time. Time that kidney's outside of the body. When you go for a living donor, your donor goes to one OR, you go to the other, and the kidney is just walked next door. So it's out of the body for a very short amount of time, usually less than an hour. There's an avoidance of any kidney injury, inflammation, or delayed kidney function. With a deceased donor, there's some sort of a trauma that's incurred that person becomes brain dead. With a living donor, that donor is very, very healthy, no trauma. Donor has limited medical issues. We don't use donors that are obese, have hypertension or diabetes, so they're actually very, very healthy. And you, as the recipient, are in optimum health. We can make sure if there's any little issues, we address them ahead of time. And you're receiving a gift of life, just like with that deceased donor. Your responsibility to take care of that for the rest of your life. Now, there are disadvantages with a living donor. The donor could be ruled out for medical reasons, psychosocial reasons. There can be a lot of disappointment. Changes in relationship, you'd be surprised. There are some families that just really can't step up to become a living donor. It's a big commitment. It's major surgery. Even though we downplay it, it's not a big deal, it really can be a very big deal to a lot of people. And so there is oftentimes a change in relationships to families. You wonder, well, gosh, why isn't my brother or sister or my mother or father stepping forward to give me a kidney? And we do support those living donors that it is very difficult for them to make those decisions. Another disadvantage is the financial impact. As I said, there's no financial reimbursement for donating a kidney in the United States at this time. So that donor has to take time off work. There's no reimbursement for travel, no reimbursement for housing. There is a new program through the Kidney Foundation where there are some financial paybacks for people who donate, but and we can talk about that individually with a social worker, but not a lot. So it does impact people significantly. So who can donate? Your living donors need to be absolutely healthy, squeaky clean, no medical problems whatsoever, non-smokers as well. So no diabetes, no hypertension, heart disease, and obesity. If you remember that first slide I showed you, one of the main reasons that people are coming to transplant is because of diabetes. We don't have a crystal ball to be able to tell whether or not that donor is going to have any medical issues in the future. We do know, though, that diabetes and hypertension can lead to kidney disease. So absolutely, we will probably not be looking at those people as potential candidates. Non-smoker, as I said, we know that smoking can lead to vascular disease, heart disease, and cancer. And if you're going to have one kidney for the rest of your life, we want to make sure that you have the best outcome possible. And then a sincere desire to donate. We don't want your donor to be pushed into this. They need to do this of their own free will. So if you have any living donors, what I want you to do is have them call the living donor line. There are brochures in your initial packet that you got when we scheduled you for these appointments. They need to call now. They can at least get started on returning the health information form. We can find out what their blood type is and get blood pressure documentation. Yes, your donor needs to be blood type compatible, but do not rule out donors yourself. Make sure, have your donors call us. We'll check their blood types. There is one blood type A2. Blood type A can be subtyped into A1 and A2. Sometimes A2 can donate to blood type O. So don't discourage anyone from calling us. We'll do the education. We'll start that process. So things to consider for donation. Multiple donors can be evaluated at one time. Have everybody call. The donor team will determine who the best candidates are to start with, and they'll work everybody up. Out-of-state donors are easily worked up. We can start the process long distance, and then they do ultimately need to come here to be evaluated, but we can do many of the tests outside of the area, as well as getting their blood drawn and shipped to our lab here. Out-of-country donors can be evaluated. The problem with that is that no blood can be shipped in and out of the U.S., so that person will need to come to the United States for an extended amount of time for that workup. And then the social worker can also help out if there's visa issues. The time frame for working up a living donor is about 3 to 6 months. I know that seems like a really long time, but it takes a while. It's a process. It's a step-by-step process. And it takes a while for records to come in, labs to be resulted, and you can't move on to step 2 till you've completed step 1. So patience. Once you start this process, you'll understand how important patience is. During that living donor workup, medical issues may be uncovered. If so, then that donor will need to have those medical issues addressed, and that will be covered under their own insurance. If that can be addressed and cured, they can come back and complete their donor evaluation. Keep in mind that we are all bound by HIPAA, the Health Information Protection Act. I can share nothing with you about your donor, nor can the donor team share anything about your medical workup with you. I can't even tell you that someone is called. If you ask me if Joe Smith is called to be evaluated, I can't share that with you. That is confidential. So just keep in mind that once we get a donor to a point where we can do what we call a cross match to see if your blood it doesn't interact, we will call you, let you know where we are in that process and that you do have a living donor. Otherwise, it's up to you and that living donor to decide how much you want to talk amongst yourselves. And then to repeat, there's no financial reimbursement for travel, housing, or time lost from work for that donor. The living donor starts with just some basic information, a health information form, blood type, blood pressures. Then once you're financially cleared, we can proceed on with their evaluation. And the very first thing that we do for the living donor is we do what's called HLA and cross-matching, where your donor's blood is drawn, your blood is drawn, it goes to the Puget Sound Blood Center, and they essentially mix it to make sure there's no interaction. For that donor to be a good donor for you, it has to be a negative cross-match, meaning no interaction between your blood and their blood. As long as it's a negative cross-match, then they proceed on with urine testing and lab work. They do multiple 24-hour urine tests, lots of labs, just like you did during your workup, so it is a process. After they complete the urine testing and they're still noted to be a candidate, then they come in here and they meet with the transplant team as well. The living donor has their own advocate. There's another transplant coordinator that works just with the living donor, so we keep it really separate. That donor will meet with a nephrologist, a surgeon. They'll have what's called a CT and CTA, which is a CT of your abdomen, and they look at your anatomy of your kidneys. We do chest x-rays, EKGs. Throughout this whole process, there may be something uncovered that would deem this donor not a candidate. So even as we get up to this final visit with the team, there's always a possibility that something could be found that could preclude them as a donor. They also are discussed in a selection conference. They receive final approval in that selection conference, and they may be ruled out or additional testing may be needed. Once they are approved for transplant, we can go ahead and set the date. Then we call you and let you know that the date's been set. So living donor follow-up, we want to make sure that we follow our donors essentially lifelong after they donate a kidney. You want to make sure that this donor has a very, very normal lifestyle and they don't have any medical issues, so we do like follow-up. We need at least yearly records and labs. So the transplant surgery. Whether it be living donor or deceased donor, the transplant surgery itself takes about 3 to 4 hours. You stay in the hospital for about 3 days, then you stay locally in this area for about a month so we can see you frequently in our clinic. The living donor surgery takes 3 hours and the hospital stay is about 2 days. People always do much, much better when they go home from the hospital. Hospital's noisy, you sleep much better at home. So when you look at a little bit of an anatomy lesson to show you where that transplant kidney goes, your native kidneys are up here, more in your back. The transplanted kidney does not go back here where what we call your native kidneys are. The surgeons place that transplant kidney down in your pelvic area. So think of where your hip bone is, and that kidney goes right next to that hip bone, sitting right down. Here's your native kidneys. Here's the transplanted kidney. Here's your bladder. Your transplanted kidney comes with its own artery and vein that are then sutured into these vessels that bifurcate and go down into your legs. That transplanted kidney also comes with its own ureter, and that takes the urine down to the bladder. The bladder is just a reservoir, a big old holding pond. Just another picture of the anatomy. Your native kidneys, or the kidneys that you're born with, we generally leave those in. By the time you come to us and start dialysis, those kidneys shrink down and they can get even the size of a walnut. On occasion, for those of you who have polycystic disease, we may want to remove those kidneys because they just get too big and they get in the way. But generally, the kidneys that you're born with stay in. We don't take them out. And then for people who are retransplant, we can always add in another kidney, so we don't always take out that transplanted kidney either. So here's just another picture of the kidney, the anastomosis, or where the artery is sutured in, the vein is sutured in, and then the ureter goes down to the bladder. A couple of side effects with surgery that can happen. Sometimes we can have what's called a hematoma, where the surgeons suture around in there. There can be a little bit of blood that leaks out, makes kind of like a little puddle, and it just slowly reabsorbs. You generally don't have to go back to surgery for that. Another thing that can happen is that the ureter is tunneled through the bladder wall, and urine is very much like water. So if your bladder does not stay decompressed or empty, sometimes the urine can leak out into your abdomen. It doesn't happen very often. The way that's treated is to have a catheter put back into your bladder until those sutures heal up really good. So one of the things that's in your transplant manual for your post-transplant responsibilities is to make sure that you empty your bladder frequently. We don't want you to hold a lot of urine in, because then that can have a little issue with those sutures. So after transplant, once we get you transplanted, then we need to bring you back and see you frequently. And a lot of what I talked about in the beginning was compliance. The key to success in transplant is compliance. We see you frequently after transplant. It's why you need your support. We need you here probably 3, 4, 5 times a week the first week after transplant. You need somebody to drive you back and forth. You need somebody to sit with you in the waiting room, because you're going to get frustrated sitting here 4 or 5 days a week. We need you here by 7:30 in the morning to get your labs drawn. The labs that we're drawing may be drug levels. We have to have those labs in early enough so we get the drug levels back the same day, so then we can adjust your drug doses to make certain that you have the best immunosuppression levels. The clinic, I want you to plan on being here about a half a day each time you come in. You'll meet with multiple people. It's a very busy clinic. You'll meet with your transplant coordinator, you'll meet with a physician, you might meet with a pharmacist, a social worker, or a dietitian. We're all here to help you get through this process. We're all here to support you, help you learn your medications, and adjust to this new lifestyle. You're a big part of the team, so we want to work together. After transplant, we'll have you return to your primary care nephrologist. We'll follow up with you, usually every 3, 6 months, and then at a year. If there's any problems, your nephrologist, call us, and you may have to come back here for a biopsy or for treatment. Your nephrologist cannot treat a lot of the kidney things or the issues that come up after transplant, so you will need to come back here. Need to make certain that you have support, transportation. You could possibly be readmitted. We talked about the emotional adjustment after transplant. And a lot of people, even though I say that it's not this absolute easy, road after transplant, people expect that, I'm going to do fine. I'm not going to have any problems. But oftentimes there's little glitches, and you do need to be readmitted. We do need to bring you in for tests. So that emotional adjustment again. Unexpected outcomes. There's a possibility that that kidney won't work. That doesn't happen very often. Sometimes people need to go on dialysis for a short amount of time until that kidney wakes up. As I said, that kidney's in shock because it's gone from one body to another. We don't know what causes sometimes a kidney to go into a shock and not work right away. So you might have to dialyze for a short amount of time. Side effects of the medications. The medications are great. We've worked really hard to give you as little medications as we absolutely can, but there are side effects to those medications, and everybody reacts differently to them. We'll work with you to help you learn your medications. As I said, there's many people that'll be meeting with you in clinic. The pharmacist spends a lot of time with you working to help you learn your medications. Once you're at home, you'll be responsible for checking your vital signs, temperature, blood pressure. You'll need to keep records for us. We want you to measure your urine output. We want to know how well that kidney is doing. There may be dietary changes. Just like on dialysis you have restrictions, sometimes after transplant you'll have restrictions as well. The one thing that we won't restrict though is your fluid intake. For those of you who are on dialysis and maybe you can only have a couple of cups of water a day, we're now going to be telling you that you need to drink 2 liters of fluid a day, water preferably. So that's a big change. We'll give you guidelines on when to call your transplant coordinator, when to call your physician. And it's up to you to take really good care of that kidney. That's a gift. Long-term, healthy lifestyle. Be active. Take advantage of this gift. Take advantage of this opportunity that you've been given. We'll want you to return for routine follow-up and kidney biopsies. You'll still need to do your regular routine health maintenance, follow-up with pap smears, mammograms, skin checks, making certain that if you have any moles, no changes. Watch your sun exposure, but be active. Do as much as you can. As I said before, success for transplant is directly related to your compliance. If you don't take your medications, if you don't follow up with your physician, you will ultimately lose this organ, this gift. So it really is in your hands to do the best that you absolutely can to take care of this kidney. And we wish you the best of luck. Thank you very much. I welcome any questions. You can certainly call me at any time. But good luck, and I'll work with you to get through this process.
Hi, I'm Lynn. I'm one of the transplant pharmacists here, and today we're going to be talking about some transplant medications. Specifically, we're going to be looking at things that you can do now to start preparing before the transplant, and then go through some of the specific medications you might be on after the transplant. We really try to emphasize of doing as much planning as you can now. Read your manual, look at your manual. Also, things that they've told you of equipment that you should get, blood pressure cuffs, thermometers, things like that. Go ahead and get those so that after the transplant, your family's not having to run around to obtain this equipment before you're being discharged. What's really important for us is really some pre-transplant planning, looking at your pharmacy benefits, looking at your insurance and financial issues. And the reason we emphasize that is that the cost of your immunosuppressants are going to be between $500 to $2,000 a month, and that's out of pocket. So this is not looking at if you have insurance. So when you look at these type of costs, most people will need help paying for these medications, so your insurance. We'll evaluate, you want to start evaluating your ability to pay for meds, and we're going to give you some tips on how to do that. So the first thing you want to look at is your pharmacy benefits and how do they work. First of all, do you have coverage? Do you understand that coverage? What type of extent is your coverage? This can work in ways of how does your copay work? Everybody in here, all of your insurance plans can be very different. Some people may have an insurance plan where your copay is about 50%. And right now with the medications you're taking, it's not a big deal for you. But when you start talking about just your immunosuppressants being $2,000 a month out of pocket, these costs can really add up. And so understanding these insurance plans is very important. You also might have multiple insurances, and these might have to be billed in specific manners. So you want to understand if you do have several insurances and you think that through all of this, you shouldn't have to pay anything, then you want to make sure that you understand that. Another important thing is some insurance companies have what we call preferred pharmacies. What this usually means is that they have a preferred pharmacy list and that you will get your best rate. You'll have to pay the least for your medications if you use what they call their preferred pharmacies. If your insurance plan has that, you want to know what those are before the transplant. Also, sometimes this preferred pharmacy might be what we call a mail order pharmacy. This is something that a lot of times they'll give you your medications cheaper if you go through a mail order pharmacy. Now this can be very beneficial for a long term for your transplant medications, but in the short term, for the first month that you're being transplanted, when you're leaving the hospital, you won't be able to use that mail order pharmacy because a lot of times they'll take several weeks to get you your medications. So if you currently use a mail order pharmacy, we want you to think about a local pharmacy in the Seattle area that you can use for at least your first month or two of medications. Finally, do you expect to receive military benefits? So you're thinking that I am a veteran, I should be able to get my VA benefits and go through the VA to get my medications. This can work wonderful as long as that you have already established care with the provider at the VA. That is the only way that they will fill your prescriptions at the VA, is if you already have a provider there. So you want to make sure you have established those type of benefits before the transplant. So insurance and financial issues can be difficult to understand. So who can you go to understand these? First of all, talk to your insurance company. Make sure you understand whether or not you have a copay. What is that copay on your medications? Is it a percentage? 50%, 10%. Other insurance companies have, if it's a generic medication, I pay $5. If it's a prescription, you may have to pay significantly more. You want to understand these type of things, so talk to your insurance company. Also, talk to your pharmacist or the pharmacy you're going to currently. They might be able to help you with the medications you're currently on and help you understand whether and how your benefits are working. Are you paying a certain percentage, and how does that all go through? So those are two options to help you start learning how to understand your pharmacy benefit plan. Also, are you staying in the Seattle area just temporarily after the transplant? Let's say you're from Alaska, you're from Eastern Washington or Idaho. Then you want to start thinking about what pharmacy are you going to be using locally. If you have a wonderful pharmacy, a little community pharmacy you use back home, and you want to use them again when you go home, that's wonderful. But when you're in this area, they may not be here. And so looking into where am I going to be staying in Seattle, what pharmacies are close by, would be beneficial for you before the transplant. Also, keep on top of your benefits. Usually at least once a year, sometimes more than that, your insurance companies will send you out these mailings on how your insurance plan is changing. You want to make sure you understand how those are changing now. This is going to be very important for you. So keep on top of any type of changes to your insurance plan. But what also happens if you lose your prescription benefit plan after transplant? We've kind of said how expensive these medications are. Well, first of all, there are manufacturer assistance programs that you might be able to apply for. There's also different type of charity programs that might be available to you. The one thing I always like to say here is that most people know that either somebody's insurance plan is changing or somebody's losing a job or changing jobs. If you know that, you usually know this way before a month or so before you're going to lose your benefits. Please let somebody know. We are much better at helping you if we have more time. It's very difficult for us to help you if we get a phone call the day that you've run out of all your immunosuppressants and say you can't afford to buy them because you don't have an insurance anymore. So let us work with you. This slide is basically just some additional web resources of different areas on the web that might have some benefits if you need help paying for your medications. And there'll be a slide of this in your packet also. In addition, here another slide with some of the common manufacturers of your anti-rejection or immunosuppressant medications that also provide assistance programs. So I want to talk a little bit about Medicare and how it works in transplant patients. For patients who are looking at renal transplant or renal pancreas transplants, there is a large percentage who are on Medicare. And the way Medicare works in transplants is a little different. Medicare Part A still pays for your hospital stays. Medicare Part B, which pays for your outpatient visits, things like diabetes supplies, has an additional coverage after transplant. Specifically is that Medicare Part B will cover 80% of your immunosuppressants. That means there's another 20% that you have to cover. So you want to make sure you realize that you're coming up on that. And that if you do have Medicare, do you have an additional coverage which will pick up that extra 20%? If you're thinking, oh, I have Medicare AB, but I also have a prescription drug plan, which I only pay $5 for all my generics and $10 for my brand name medications. Well, if it's a Medicare Part D program, then since you have Medicare Part B, you have B and D, since your immunosuppressants are covered under Medicare Part B, if D is the only other coverage you have, they will not pick up that extra 20%. And so you would need either to pay that out of pocket or have an additional insurance plan. This slide has some examples of some what we call transplant pharmacies. These are examples of some mail order retail pharmacies. The reason we put them up here is that a lot of times when you're coming into the hospital, we're going to ask you about your insurance plan. And if we see that you're going to have multiple levels of billing, it has to go to Medicare, and then it has to go to 3 other insurance companies after that. These type of pharmacies kind of specialize in this area and have dealt with a lot of transplant patients currently and in the past and understand the complex billing process. So if you're looking for a new pharmacy and we see you have a complex billing, we might suggest that you look into one of these pharmacies after the transplant. So now you're being called in for the transplant. What should you bring with you? I usually suggest for patients either keep yourself a little list, something so you're not trying to run around your house to get things together, so it's a little bit less hectic for you. But keep yourself a list of things you need to bring in. You want to bring in your manual. There'll be downtime in the hospital. You might want to go back through and read through some of the aspects of your manual. Bring in any equipment, the blood pressure cuff, things like that, to make sure that they can test it with a nurse and make sure that you understand how to use it or verify that it's working appropriately. For pharmacy, of course, we want you to bring in a current home medication list. We even suggest go ahead and bring in your medications with you. We may not have seen you for a little while. We need to know what you're on. We need to know the name of the medications. We need to know the dose. We need to know how often you're taking it. That way we can look at your medication list and make sure that we keep you on medications that you need to be kept on, and also be able to tell you which ones are going to be specifically stopped after the transplant. So please bring all that in with you. In addition, make sure you have all your insurance cards with you. The insurance cards are very important in that after the transplant, if you're choosing a new pharmacy or going somewhere different for your medications, we can help provide those insurance cards to the pharmacy so they can start looking at your insurance and start billing that right away after the transplant. After the transplant, you're going to meet with me or one of my colleagues, and what we're going to do is we're going to go through, it's about an hour of medication teaching with you and your caregiver. The first thing that we're going to provide you is going to be, this is just an example list of a medication list. This will be personalized to you and will only reflect the medications that you will be on. On this medication list, it lists the name of the medication. Along with, we have a taped on or a picture of what your medications are going to look like. Next to that, we also have the function, because we want you to understand why you're taking the different medications. And across the way, it tells you exactly which times of the day that you'll be needing to take these medications. So every patient will get their own personalized medication list after the transplant. You're also going to receive a medication box. Some of you may have already be using one of these medication boxes at home. This one is set up so it corresponds to your medication list. It's a week's worth of medication, and it's broken down into 4 times of the day so that we'll be able to fill this medication box while you're in the hospital. So while we're meeting with you and your caregiver, we'll go through all your medications, we'll go through what you're using it for, we'll go through certain side effects that you may experience with these medications. We'll actually have you fill your medication box before leaving the hospital, and have you start taking your own medications, usually about 24 to 48 hours before you leave. That way you're kind of getting used to the process, you start understanding when you're supposed to take the medications. You also have people helping you. So if you have questions or concerns, people are there to help you. There'll be nurses around all the time, the pharmacists are there, and if there's specific questions, we'll come back and review things with you. So you'll be able to get this teaching before you leave the door. Since you start taking your medications before you leave the hospital, your medication box will have about 3 to 5 days of medications left in it when you leave the hospital. Therefore, it's going to be very important that you've already picked out what pharmacy you want to use. That way we can get the prescriptions to your pharmacy as soon as you're being discharged. This is important in that, as we've kind of talked about, sometimes insurance can be a little bit difficult. Sometimes there's multiple billing steps that are involved. And so you want to give your pharmacy ample time to get these medications processed. And since you only have about 3 to 5 days worth of medications, then it's really important for them to have that time. Just as a summary, we want you to make sure you also fill all your prescriptions at the same pharmacy. Plan ahead. These medications aren't like other medications you've taken in the past. You can't be like, oh, I need to call in tomorrow to get my anti-rejection medications. You can't run out of these medications. Running out of the medications and missing doses puts you at risk for losing your new organ. So it's very important to plan ahead. Call in several days before you need the medication. Allow your pharmacy time. If in case they need to, they can order it in. They usually can get about anything in about 24 to 36 hours, but they need that time. Refill your medications early. And keep on top of when you do need to have your medications refilled. So now we're going to move over to medications and different type of medications that you'll be on after the transplant. The goal, the primary medications you're going to be on are what we would call immunosuppressants. You're also going to hear everybody calling them anti-rejection medications. The goal of these medications is either to prevent or treat rejection while minimizing the risk of infection. So why do you have to take these immunosuppressants? Well, if we transplant a new organ to you, if you have a new kidney or new pancreas, if you stop taking these medications, then your body is going to recognize that that organ is not your own, that it's a foreign organ. So what these medications do is they kind of trick your body. They fool it into not recognizing that. So it suppresses your body's immune system by decreasing the effect of your white blood cells. Now you might probably be on different immunosuppressants. Most patients will be on at least 2, maybe even 3 immunosuppressants. Each of these medications works a little bit differently, and a lot of times we use them together so that we can reduce your dose, and which will reduce your side effects to these medications. So for how long do you have to take your immunosuppressants or your anti-rejections? You need to take these for as long as you have the transplanted organ. Doses initially after the transplant will be much higher, and as you get further and further out from your transplant, we will start decreasing the dose to a lower maintenance dose. We'll go through in the hospital why, again, you need to take these, when you need to take them, how to take them, but it's really up to you. We can't make you take these medications. We can just tell you that if you don't take these, then you will reject your new organ. So it is up to you. We'll give you different pointers. This is a new lifestyle change for many people. And so we'll try to help you with like setting alarms, setting cell phone alarms, things to help you to remember to take your medications. Now everybody's medication regimen could be different. So if you have a friend or you start knowing other patients who have had transplants, you might think, well, they're on this regimen, why am I not? Every patient's medication regimen is specific for them. It depends on other disease states they have. It depends on their specific factors at the time of transplant. So everybody's regimen will be a little bit different, and your surgeon will determine that. What we really try to do is customize these regimens for what is best for you. So now I'm going to start talking about some of the medications that you'll be on at the time of transplant. The first two medications I will speak about are only given in the hospital. You won't be going home with these. We call these induction agents at the time of transplant. The first one is called basiliximab or Simulect. Some patients will receive this medication. This is an antibody which blocks the activation of your T lymphocytes. Usually you receive the first dose in the operating room and then a second dose 4 days later. This medication is pretty well tolerated. What most patients complain of are more like allergy symptoms, fever, chills. So most patients tolerate this one very well. The second medication, and this is also one that you would only receive in the hospital, is called thymoglobulin, or ATG. Some patients will receive this medication. This one is a medication that's made up of antibodies that actually destroy your human white blood cells. This is a much more powerful agent than the first one. You receive the first dose the day of the transplant, and then usually about 3 to 4 doses afterwards on alternating days. With it being a more powerful agent, patients usually complain of more side effects with this medication. We will actually pre-medicate you to help minimize some of these side effects. Most patients would experience things like flu-like symptoms, fever, chills. They can have headaches, nausea, shortness of breath. For the first dose, we infuse this medication very slowly to make sure that you tolerate it okay, and we'll watch you for these side effects. So now we're moving on to medications that you're going to be going home with. These are medications that you're going to be on for the rest of your life. The very first medication is called tacrolimus, or Prograf. Another name for it is FK506. We want you to become familiar with all three names because your physicians are going to use these interchangeably. They're going to say, what's your FK dose? What's your FK level? What's your Prograf dose? And so we want you to become familiar with all of these names. This one decreases the activation, growth, and function of your white blood cells. You will begin taking this one by mouth in the hospital as soon as your kidney begins to function. This one is taken every 12 hours, and we will set that up that you take it at 8 o'clock in the morning and 8 o'clock at night. And I'll get to that for why those times are very important. The reason we want you to take this medication at 8 o'clock in the morning and 8 o'clock at night is because we're going to be drawing blood levels of the tacrolimus. I can't look at you and say, because you're male or because you're female and you weigh this amount, that we should give you this amount of medication. The way we know is that we monitor blood levels. And so we will have blood levels drawn before your morning dose, so before that 8 a.m. dose. And for us to make sure that we adjust that dose correctly, we need to know what time you're taking that medication. And so that's why these times are very important. We don't want you to be taking your medications at a different time, and then we're going to adjust your dose inappropriately because the level is not correct. On clinic days, and we'll go over this in the hospital, this is one of the medications that you cannot take before you come in to have your blood draws. That's because we're looking for this level. And so we'll wait until after you've had your blood drawn on clinic days to take this medication. So the potential side effects of tacrolimus, or Prograf. Ironically, it can cause some decrease in kidney function. This is why we need to monitor your levels very carefully. If your levels get too high, you have an increased incidence of causing some kidney damage. This is why making sure that you take the medications at 8 o'clock in the morning, 8 o'clock at night, and that we draw a blood sample in the morning before you come to clinic, usually about 7 o'clock in the morning, is so important, so that we make sure that we're not adjusting your medication incorrectly to put you at increased risk for things like decrease or to cause harm to your kidneys. Some patients will have an increase in their blood pressure. If you're already on blood pressure meds, some people will notice that we might have to increase your dose. Even if you've never been on blood pressure meds before, some patients will require blood pressure meds after transplant. It can affect some of your electrolytes. It can cause your potassium to go up, your magnesium to go down. We're going to look specifically for some shaking in your hands. We'll look for that in clinic, but we want you to tell us about these side effects. If you think you're experiencing any side effects, please let us know, and we'll look to see if there's something that we can do to help you with that. So just to continue on, people can have headaches. A small percentage of patients could have seizures from this. Increased blood sugar, increased cholesterol. These are all things that we're going to monitor for. The next medication that everybody will be on is called mycophenolate. It can also either be called Myfortic or Cellcept. This one decreases the production of white blood cells. Some patients will take this along with the tacrolimus and prednisone, and this one is also taken twice a day. The side effect for this medication that most patients tell me about are things like nausea, diarrhea, upset stomach, abdominal pain. We want to know if that occurs with you. We still want to know. We know it's a common side effect, but there's things that we can do. Other things that we're going to look for with this medication is sometimes patients will have a decrease in their white blood cell count with that. Something we look for in clinic. We check your labs for this. If it occurs, we would decrease the dose, or we might have to stop it. The last immunosuppressant or anti-rejection medication we're going to talk about is called prednisone, or you probably hear this called steroids. A lot of people have been on this medication for many different reasons. This one decreases the function activity of white blood cells also. Initially, normally the doses are much higher post-transplant, and over time we will taper or decrease your dose to a smaller single daily maintenance dose. So over the short term, why we want to get this medication down to the lowest possible dose is that with higher doses there are some significant side effects that we want to avoid. Of course, you have stomach upset, heartburn. Some people can get stomach ulcers at very high doses of steroids. It can cause emotional changes. What I talk about are mood swings. Usually sometimes the patient's family is the first one to notice this because they're not acting quite themselves. So it can cause some significant mood swings at higher doses. You can have an increase in your blood pressure, increase in blood sugar. So patients who are diabetics, who are already on insulin, can see that they have a significant increase in their insulin requirements with high doses of prednisone. And weight gain, blurred vision. These are all things that can occur at high doses of steroids or prednisone. So we try to get the dose of the prednisone down as low as possible. So some of the long-term potential side effects, even with low doses, can be muscle, bone, and joint weakness. You're at risk for developing osteoporosis. Weak, dry, thin skin, so people usually complain of easy bruising. We'll have to monitor your cholesterol, and your vision needs to be monitored closely because of the risk of cataracts. It's also important if you're on prednisone is that when we're working with you for good exercise, good nutrition are really vital if you're on prednisone to kind of minimize some of these long-term side effects. So now I'm going to kind of move on. We've kind of gone over the main immunosuppressants or anti-rejection medications. The next medications I'm going to talk about are what we call antibiotics. These medications you're only going to be on for a short period of time after the transplant. With the transplant, we're giving you large doses of immunosuppressants. This really brings down your immune system, which makes you more susceptible to infections. You're more at risk for developing certain type of infections. So we're going to give you certain antibiotics to prevent very specific infections early on in your transplant. First ones we're going to talk about are either called clotrimazole if you're having a kidney-only transplant, or fluconazole or diflucan for a kidney-pancreas transplant. Both of these medications are what we call antifungal or anti-yeast medications. What these medications do is that all of us have yeast in our mouth. But with the transplant, we're giving you medications that really bring down your immune system. And so you can develop an overgrowth of this yeast in your mouth. So you'll take these medications for 3 months post-transplant. At that time, your immune system is, we're decreasing the dose of some of your immunosuppressants, so you're not as much risk for this overgrowth of yeast. So we'll stop at 3 months post-transplant. The next medication we're going to talk about is called valganciclovir, or Valcite. This is an antiviral medication. This one prevents or treats different type of herpes infections or infections called cytomegalovirus, or CMV. Most of us are exposed to these. If you've ever had a cold sore, that's a herpes virus. The cytomegalovirus is something that a large percentage of the population is exposed to. It's just that normally it does not become active in us because we have an immune system. So when you come in for the transplant and we give you these immunosuppressants, it puts you at risk for reactivation of this cytomegalovirus in your body. So we're going to give you a medication for the first 3 months post-transplant to prevent this reactivation. Some of the side effects with this that specifically we're really going to look for are decreases in your white blood cell count. And so we'll monitor for that in clinic. The last antibiotic that you're going to be on is called Bactrim. Everybody will call it Bactrim because nobody wants to call it trimethoprim sulfamethoxazole. We always have it up there though because your prescription bottle will have that written across it, and everybody's like, what is this? It's your Bactrim. This is an antibacterial medication. We're going to use it for 2 purposes. 1 is to prevent urinary tract infections. 2, it prevents a lung infection called pneumocystis. This is a medication that you just take 1 tablet at night for the first 6 months for most patients, and then after 6 months we'll stop this. This is a medication that increases your risk for things like sunburns, things like that. So with the transplant education, where you have to be very careful using sunscreen, in addition to medications that we're going to give you, like Bactrim, which puts you at risk for to burn more easily. So the use of sunscreen is going to be very important. So now we've kind of gone through all your immunosuppressants. We've also gone through antibiotics that you'll be on, and the rest of these I kind of call them as more supplements, things that you'll need in addition to. The first one is called ranitidine or Zantac. This one decreases stomach acid. We hope to prevent stomach upset because you're going to be started on a bunch of new medications, and a lot of these will cause some stomach upset, nausea. And so early on we want to help prevent that. So we use this for the first 3 months, and then we'll stop that. If you're already on a medication, something like Prilosec, Prevacid, something like that, we would not change you over to Zantac. You would still remain on your home medication. This next one, these next 2, is called Docusade or Dulcolax. These are 2 separate medications. One is a stool softener, the other is a laxative. This one is to prevent constipation and hard stools. We'll usually have you take these for about 3 months post-transplant, but we just work with you. Usually one of the biggest problems is that patients will require pain medications after the transplant. And one of the biggest problems with pain medications is constipation. And so we'll work with you and provide what you need for that. In addition to everybody will go home on a multivitamin. We'll start you off on a prenatal multivitamin because it kind of has the most complete multivitamin there is. Next, you also go home on calcium and calcitriol. This is to help prevent bone disease or osteoporosis. We'll usually use calcium carbonate, and the calcitriol is a form of vitamin D. The vitamin D actually helps you absorb the calcium better. So as I kind of say, you get a little bit more bang for your buck when you're taking them together. Next, patients will also get a baby aspirin. This one is to help prevent clotting of blood vessels that are leading to your new organ. We'll also have you take this indefinitely. This next medication is called amlodipine or Norvasc. This is a blood pressure medication. It helps bring your blood pressure down. This is just kind of an example. This is a common medication that we would use if we needed to start a new blood pressure medication on you. Next, we have other supplements, and we'll just work with you. We're going to look at your labs. As I kind of spoke of earlier, the tacrolimus, also called Prograf, can cause a decrease in your magnesium levels. Sometimes we might need to give you magnesium to replace that. The other one, sodium phosphate or sodium bicarb. We'll just kind of work with you. We'll look at your electrolytes and see what you need, and we'll provide those for you. So at Transplant Clinic, what do you need to bring with you? We're going to have you bring everything with you. Bring your medication box. Bring your medication profile that you've been given. Bring your records. You're going to be keeping your blood pressure. If you need to monitor your blood sugars, you're going to have a record for that. Bring that all with you. Keep track of all the changes that are being made. And always ask questions. Usually always try to remind patients when they're leaving the hospital that to write your questions down, because usually you remember about 5 questions as soon as we all walk out the door. So write all your questions down so that when you're seeing us in clinic, we make sure we address all your concerns. Now, take only the medications prescribed by your doctor. This is very important now in that we want to make sure we know what you're taking with these new transplant medications, the immunosuppressants. If you have a good friend saying, oh, you have a cold, I always take this nice little herbal product and it cures everything for me, please call us. We do not want you taking any herbal medications. The reason this is very important is that your transplant medications, your Prograf, your main immunosuppressants that are going to keep you from rejecting your new organ, interacts with a lot of medications, okay? And so we don't want you to have your levels get too high and have side effects from the tacrolimus because of a drug interaction. We also don't want your levels to get too low because of drug interactions. And that will put you at risk for losing your new organ. So please let us know. Also, if you're thinking you're having a side effect, let us know. It might be something that's rare that we haven't specifically talked about here. And so let us know and we'll see what we can do. So I've kind of spoke about how important it is to take these medications at 8 o'clock in the morning, 8 o'clock at night. But what happens if you miss a dose? Well, that's one of the reasons we're going to try to help set up reminders early on, setting alarms, things like that to help until you get into a routine. But if you miss a dose, if it's close to your dose, you're supposed to take it at 8 o'clock in the morning, it's 10 o'clock in the morning, you realize you overslept, you didn't take your meds, take your medications. If it's close to your next dose, it's 8 o'clock at night and you realize you missed all your morning meds, do not double up on your medications. After that, just give us a call. Give your transplant coordinator a call for any further instructions. Always carry a list of your medications with you. Keep an updated list. We usually recommend for after the transplant, if you can keep your medication list on a computer at home or have somebody help you keep it on a computer at home. Early on, your doses can change quite a bit. Medications might be added, stopped. And so you want to be able to easily go in and change what your medication list is and keep an updated list on you. Also, of course, notify all your other healthcare providers, whether it's dentist, any other physicians you have that you've had this transplant, and give them an updated list of your medications. So thank you very much for your time, and good luck.